Good morning, everyone. Myself, Dr. Gokulakrishnan, working as a senior resident in Department of Pediatrics in Sri Lakshmi Narayana Institute of Medical Sciences, Puducherry. So today we are going to have a short discussion on a topic called approach to floppy infant. So the objectives of the class are we will be dealing with the introduction part, etiology for floppy infant, clinical approach, history taking, physical examination, lab investigations, principles of management, and take-home points. So what is floppiness? So basically, floppiness in an infant can be described as either hypotonia, where the tone is low and the child is strong. So it is called as floppy strong. The second category is weakness. The overall body is weak. The tone is also, the child is also floppy, and on examination, the child is weak. So it is mainly categorized into two categories, floppy strong and floppy weak. And the third category is the ligamentous laxity. So where the mobility of the joint is increased. So now the floppy infant syndrome generally includes the first two conditions, whereas the third ligamentous laxity, which denotes the increased joint mobility, usually indicates the musculoskeletal part. So our area of concern is the floppy infant is a neurological cause. Either it could be a hypotonic child or a child with weakness. So what is tone? Tone is nothing but the resistance offered by a resting muscle against a passive stretch. So whenever you are passively stretching a child muscle or a part of a body, the child involuntarily offers some resistance, and that is being described as tone. So there are basically two types of tone. One is the phasic tone and the postural tone. What is phasic tone? So basically the phasic tone is described as a rapid contraction in response to a high intensity stretch. For example, while we are checking a deep tendon reflex, so on examination of a knee jerk, there will be a rapid flexion of the knee. There will be a rapid flexion and the reflex is present. That is a phasic tone. What is a postural tone? For us to maintain a standing posture, all our anti-gravity muscle has to act. For example, the leg muscles should make us stand, and the upper limb muscles, the triceps and the supinators, everything should act so that to maintain a posture. Similarly, when we lie down, the muscles of the back helps us in maintaining the posture. So that is a postural tone. So the maintenance for a body to maintain this tone, both phasic tone as well as the postural tone, the central nervous system should be intact. That is, the brain and the spinal part should be intact, and the motor unit, which is the peripheral nervous system, like anterior console, peripheral nerve, neuromuscular junction, and the muscular compartment, everything should be normal. So the developmental delay in case of a floppy infant is extensive, and systematic approach will help in the localization of the problem. So once you come to see a case of floppy infant, you should see whether it is a floppy strong or a floppy weak, and you should localize where's the problem, whether the problem is in the central nervous system or the problem is in the motor unit. So moving on to the physiology of the muscle tone. So how is the muscle tone regulated? So if you see the motor cortex, from the motor cortex, the corticospinal tract goes to the spinal cord. And also from the premotor cortex, the tracts like cortico-reticular tract, right, which relays in the medullary reticular formation in the medulla. From that, the dorsal reticulospinal tract descends downwards. And similarly, from the pontine reticular system, a tract called the medial reticulospinal tract, and from the lateral vestibular nucleus, which organizes the position, the vestibulospinal tract. So all these higher centers contributes a tract which enters the stretch reflex circuit. The stretch reflex circuit is in the spinal cord. So once they reach, they organize the muscle tone. If you see the motor cortex, the corticospinal tract promotes an inhibitory action on the stretch reflex circuit. It prevents the body from getting excess stretch. There is always a constant stretch provided by the motor cortex, corticospinal tract. Similarly, the other tracts like pontine reticular system in the premotor cortex and the lateral facilitates the stretch reflex. So in body, always there is a check between the facilitatory pathway and the inhibitory pathway. Facilitatory pathway promotes and facilitates the stretch reflex. The inhibitory pathway keeps a check and inhibits the stretch reflex. So this is the physiology of the muscle tone. So broadly, we classify hypotonia into central hypotonia and peripheral hypotonia, which we have discussed in the first slide. The central hypotonia is nothing but the floppy strong. The child will look floppy, but on the examination of the deep tendon reflexes, the reflexes will be exaggerated. So the problem is predominantly in the upper motor neuron lesion. Similarly, the peripheral hypotonia, which means a floppy weak, the child is also floppy and the tone is also low, hypotonia is present, and the reflexes is also very weak. So it constitutes the peripheral hypotonia. So if you see the overall causes, the central causes always outweigh the peripheral causes. Almost 60 to 80% of cases in our country is always because of the peripheral hypotonia. Central hypotonia. So now let's see a few conditions which are associated with central hypotonia. So central hypotonia is a condition where the child is floppy strong and predominantly affecting the brain and upper motor neuron. So the brain and the tracts which are coming out of the brain. So the causes are hypoxic ischemic encephalopathy, which affects the brain, neonatal hypoglycemia, which affects the brain, some cerebral malformations, congenital cerebral malformations, intrauterine infections, predominantly the torch infections like toxoplasma, rubella, cytomegalovirus, herpes virus, chromosomal disorders like Down syndrome and Prader-Willi syndrome. These are the causes of central hypotonia. Metabolic disorders like inborn errors of metabolism. So hypothyroidism can also cause central hypotonia. Rickets can cause central hypotonia, renal tubular acidosis, and hypokalemia. And connective tissue disorders and IEMs, other IEMs like organic aciduria, urea cycle disorders, and MPS mucopolysaccharidosis. And all sick neonates, they will be having a central hypotonia. The newborn admitted in NICU with sepsis. Now, let's discuss the few causes of peripheral hypotonia. So, the problem is in the motor unit. So, what are the constituents of the motor unit? It consists of the anterior concept, the peripheral nerve, the neuromuscular junction, the muscle compartment. All these contribute the peripheral hypotonia. So, any problem in these sites will contribute to the peripheral hypotonia. So, the conditions associated with peripheral hypotonia are pathology involving the anterior concept, spinal muscular atrophy, pathology affecting the peripheral nerve, like congenital hypomagnetic neuropathy or Beecher-Sotos syndrome, which is a peripheral neuropathy. Conditions affecting the neuromuscular junction, which is a transient neonatal myasthenia and congenital myasthenia. Muscles, disorders affecting the muscles, like congenital myopathy, congenital muscular dystrophy, which includes the Duchenne's muscular dystrophy, Becker's muscular dystrophy, Emery-Dreifuss muscular dystrophy, facioscapulohumeral muscular dystrophy, and congenital myotonic dystrophies, and metabolic myopathies. Metabolic myopathies are myopathies secondary to the inborn errors of metabolism, like the Pompey's disease or the mitochondrial myopathies. So, when will you suspect a case of floppy infant? So, when to suspect? So, the major thing which helps us in identifying this floppy infant is whenever the mother feels the baby is floppy. When the mother feeds the baby, or when the mother changes the dress or changes the diapers of the baby, she feels that the baby is very loose and as if the baby slips off her hand very easily. And when she observes there is very decrease in movement of the limbs, or when there is, as I told, when there is a difficulty in feeding, the baby is not sucking properly, or the suck is not so strong, or the cry of the baby is abnormal. Abnormal in the sense the cry is very, very weak. There is not a normal, forceful cry. And when there is a positive family history, which suggestive of developmental delay or sibling death. When a baby is floppy and there are other contributors like the history of developmental delay in any of the siblings or the elders, or whenever there is a history of sibling death, always suspect this could be a metabolic cause of, always suspect that this could be a metabolic cause of floppy infant. So what are the other histories which adds to the features of a floppy infant? So Important histories in the antenatal history, like history of decreased fetal movement, has to be asked in cases of whenever you have a floppy infant. So, example, in cases of congenital myopathies or congenital muscular dystrophies or congenital myotonic dystrophy, the mother classically gives us the history that the fetal movement, there is a decreased perception of a fetal movement. And when there is polyhydramnios, so whenever there is a myopathy or muscular dystrophy, the oropharyngeal muscles and the pharyngeal muscles or the swallowing activities are very poor. So because of this, the amniotic fluid consumption is very, very less, followed by which there is polyhydramnios. And when there is a breech presentation, always suspect. When the baby is floppy and the antenatal history indicates the baby has breech presentation, always suspect floppy infant. And as we discussed, intrauterine infections or maternal infections like torch infections like toxoplasma, rubella, cytomegalovirus, herpes virus, or drug intake, maternal drug intake. For example, mother receiving magnesium sulfate in view of eclampsia during the antenatal period, because this magnesium sulfate is a smooth muscle relaxant. So it's a calcium blocker. So because of that, the baby will be very floppy. Few important histories which has to be asked in the perinatal period is history of use of general anesthesia or sedatives. For example, a mother who has been operated for a lower segment cesarean section receiving general anesthesia, the drug has been transferred through the placenta to the mother. And history of sedatives like benzodiazepines or any sedative drug intake in the mothers like morphines or opioids, or history of birth injury causing hypoxic ischemic encephalopathy, um, birth injury causing intraventricular hemorrhage. All these histories has to be noted. These are the important and relevant histories. And history of requirement of resuscitation, a baby with low Apgar score, a baby requiring positive pressure ventilation uh, during uh, during the newborn period, baby didn't try at birth, and baby has a very low Apgar score at first minute and fifth minute. All these diagnostic considerations has to be noted. And important postnatal histories are baby developing seizures in the newborn period. These contributes to the central cause. Floppy strong babies, babies with cerebral malformations, babies with hypoglycemia can have seizure. Symptoms suggestive of neonatal encephalopathy, altered sensorium, coma, poor feeding, and the onset and degree of weakness and the progression are all very, very important, because in hypoxic ischemic encephalopathy, which is a central nervous system cause, the problem affecting the brain, the baby will evolve into hypertonia. The baby will be floppy, but it's a floppy strong. Later, initial evolution will be hypertonia, and later it goes into hypotonia. Like hypotonia evolves into hypertonia. And history of intake of honey in the newborn period is very, very important, which guides us in diagnosing the infantile botulism. Family history, like history of consanguinity, is very important, because whenever there is history of consanguinity, the histories like autosomal recessive disorders like metabolic myopathies or inborn errors of metabolism can be considered. History of developmental delay or any neuromuscular disorder or any sibling death, which has been discussed in the previous slide. Like whenever there is a history of developmental delay in any of the family members, we should always consider the congenital cause and always look at the mother's face. Ask the mother to make the fist and release quickly to check for myotonia, because this myotonic dystrophy is a condition which has been transferred by the mother to the baby. It's an autosomal dominant condition. That is a phenomenon of anticipation. So when the baby is floppy, always look at the mother's face. Check for any myotonic faces, or whether there is inverted V-shaped upper lip, whether there is temporal following, or whether there is delayed grip, whether there is delayed reflection, the delayed relaxation of the tendon reflexes, all the myotonic grip has to be examined, and release sign, myotonic release sign, all these has to be examined so that the diagnosis can be made easy. Developmental histories, as we discussed earlier, history of delayed developmental milestones has to be asked. Moving on to the physical examination, general examination, whether the child is interested in the surroundings and the pattern of cry. As we discussed earlier, the child with floppy infant will have a very weak brain and interested in surroundings. For example, when the baby has a central hypotonia, the baby will be having a developmental delay. But the baby with peripheral hypotonia, where the pathology is in the motor unit, the baby will be alert, active, and look around the surroundings. Like examples like spinal muscular atrophy, where the baby is very floppy and weak, but by the appearance, the baby looks interested and looks through the surroundings. Vitals, whether there is any tachypnea, increased respiratory rate, or abnormal pattern of breathing. Because in peripheral hypotonia like SMA, the intercostal muscle weakness and in congenital myopathy, the intercostal muscle weakness and the diaphragm weakness are more dominant. So because of this, the baby will have an altered pattern of breathing. So these babies are more prone for respiratory failure in the future. So and also there is greater risk of aspiration. Because of this, there may be incidence of aspiration pneumonia and the respiratory rate is increased. So always look whether there is tachypnea is there or the pattern of breathing is normal or abnormal. Then get to toe examination. Check for facial dysmorphisms. As I told earlier, check for Down syndrome faces for Prader-Willi syndrome. Okay, and also check whether there are faces for any stigmata for congenital torch infections, cases of myopathy, like eye arched palate, drooping eyelids for myasthenic gravis, V-shaped upper lip pattern, and temporal following for myotonic dystrophy. All these dysmorphic features has to be examined in every child. Microcephaly or macrocephaly. So when central hypotonia, the cause the pathology is in the brain. So the brain growth is affected. So you should always check the head circumference whether microcephaly is present or not. So when the baby is floppy and there is associated microcephaly and associated dysmorphic features with history of seizures, it's directly helps us in diagnosing a central hypotonia. So it's an easy way of diagnosing before even checking bone and flexes. Check for tongue fasciculations. So tongue fasciculation is commonly seen in anterior onset pathology, motor unit. So spinal muscular atrophy can cause tongue fasciculation. Chest shape and deformity. So baby with spinal muscular atrophy will have intercostal muscle weakness. So because of that, there will be presence of a bell-shaped chest with paradoxical breathing. So when the child tries to inspire, the abdomen goes inside instead of coming outside. And when the baby tries to expire, when they expiration of the air or exhale, the chest goes outside. So that's a paradoxical breathing. And musculoskeletal problems like hip dislocation or club foot because of this floppiness has to be examined. On organomegaly, like inborn errors of metabolism, storage disorder causes, there will be associated organomegaly. And microplates in Prader-Willi syndrome, and height has to be examined. Short stature is seen in Down syndrome, Prader-Willi syndrome, and when whether there is a history of nasogastric tube feed, because these babies will have poor swallowing reflexes and these babies will have respiratory failure. So if you took to examination, requirement of respiratory support in history of continuous nasogastric tube feeding is very important. So this is an example of myotonic dystrophy. If you see the mother's faces, she has a temporal hollowing with flat philtrum, with flat V-shaped upper lip. Okay, and she has a expressionless faces. Similarly, if you look at the baby's face, the baby also has a V-shaped upper lip with open mouth and mild drooping of eyelids with smooth philtrum. So by examining the mother's face, so in this case, what are the reflexes has to be checked in the mother? Reflexes like delayed myotonic grip myotonia or myotonic release sign has to be examined. So the mother is asked to hold the thumb and the index finger of the examiner, and it becomes very difficult for her to relax when you ask her to relax the muscles. And using a knee hammer, the thenar eminence has to be stroked. After the contraction, there is delayed relaxation of the thenar eminence. So these are the signs which has to be elicited in the mother. Now, this myotonia to develop in the baby, it takes at least 2 years. So it's very difficult to elicit these signs in the newborn baby. So, which is the important cause of central hypotonia, which we have discussed, is the Down syndrome. So, Down syndrome, the main criteria for diagnosis is the Hall's criteria. So, as per the Hall's criteria, hypotonia, poor motor reflex, flat faces, upward slanting palpebral fissure, and small dysplastic gears. So all these are the major criteria which can be used to directly diagnose the Down syndrome. And other criteria in musculoskeletal, the child is very floppy, so there will be joint hyperflexibility. And also the neck will be short and the skin is redundant in the sense there will be a loose fold of skin. And the fifth digit will be curved. So that's a clinobacterium. And the pelvic dysplasia, the pelvic bones are not properly developed, and there will be a simian crease. If you see a palm, there will be a single transverse palmar crease, which is called as the simian crease. So these are the major criteria which can help us in diagnosing the Down syndrome. There are other features which are seen like developmental delay. Child will be having a flat occiput and brachycephalic. The width of the skull is more. The child will be having epicanthal folds. So these are the epicanthal folds, and there will be delayed closure of the fontanelle, and the baby will be having a small nose. Baby will be having heart disorders. So the common heart disorders like endocardial cushion defects, patent ductus arteriosus, Willis disease, pathology of Fowler, and atrial septal defects. All these are identified. And other features like the baby will be having short metacarpals and phalanges of the hands. The sternum is very short. The baby will have gastrointestinal complaints like duodenal atresia, and tracheoesophageal fistula, Fitzgerald disease, neonatal cholestasis. So all these are the clinical features which are observed in a baby with Down syndrome. Among this, the 9 Hall's criteria which has been highlighted in this slide are the which helps us in identifying the which helps us in easy identification of the Down syndrome. So next is the Prader-Willi syndrome. So if you see, this is the Prader-Willi syndrome. The baby at birth, the baby will be a small for gestational age baby, and around 1 year of age, there is a rapid weight gain associated with hyperphagia and excessive weight gain. So during the course, this baby will have developmental delay, and there will be the baby at birth, the baby will be having failure to thrive and poor feeding difficulties and hypotonia. As the age increases, the weight gain of the baby increases and the hyperphagia increases, and the baby will be having excessive weight gain and delayed puberty. Apart from the delayed puberty, other endocrinological disturbances like short stature will be the baby will be having precocious puberty, and there will be behavioral disturbances like intellectual disability, poor social skills, poor emotional skills. Moving on to the CNS examination in the case of a floppy infant. So higher mental function is very, very important. As I discussed in the previous slide, higher mental function like baby's alertness to the surroundings, the cry of the baby, and the interaction with the surrounding is very important. So when there is a central hypotonia, the alertness is poor and the interaction with the surrounding is very poor. But in cases of peripheral hypotonia, the baby will look alert, the cry is good, and the interaction with the surrounding is good. Cranial nerve examination. So this cranial nerve examination is commonly seen in myasthenic brain disorders, like there will be bulbar palsy in congenital myopathies, where the lower cranial nerve palsies are more common, like pseudobulbar palsy, like cranial nerve 9, 10, 11, 12. In myasthenia gravis, the upper cranial nerves, like cranial nerve 3, 4, 6, which contributes to the extraocular muscle movements and the muscle which contributes to the facial strength or paralysis. So when there is a floppy baby with ptosis, which means the drooping of upper eyelids, and ophthalmoplegia and squint, always suspect myasthenia gravis. When there is facial weakness, lower cranial nerve involvement, cranial nerve 7, cranial nerve 8, 9, 10, and 11, always suspect congenital myopathies. So involvement of cranial nerves will also help us in diagnosing the floppy infant, and it can even help us to narrow down our differentials. And bulk, as we have discussed, uh, bulk of a muscle, generally the bulk is very loose or the muscles are very, very loose. But there are some conditions like Duchenne's muscular dystrophy or Becker's muscular dystrophy where the muscles are hypertrophic. Especially this hypertrophy is seen in the calf muscles. So examination of calf or examination of the gastrocnemius muscles are very important. So this hypertrophy is not a true hypertrophy, it's pseudo hypertrophy in the sense that there is a deposition of fat. So the muscle fibers are replaced by fatty deposition. Power. As we discussed earlier, the power, the quantity of the movement is also very, very important. In peripheral hypotonia, the babies will be floppy weak. Moving on to the tone examination. So inspection, the general attitude of a baby is very, very important. So always see whether the baby has a normal position or a frog-leg posture. The frog-leg posture is most commonly seen in the peripheral hypotonia, where the baby is floppy weak. The baby will be alert, but the limbs will be as of a lying down frog, where the legs and hands are very, very weak. And on palpation, the muscles would be very flabby. Muscles are very loose and flabby. The exception for this is Duchenne's muscular dystrophy, where the muscle has pseudo hypertrophy. And examination of passive tone. So when you do an arm recoil test or a rib recoil test or scarf sign or heel to popliteal angle or heel to ear test, there will be the limbs will be very loose and these signs are very, very easy to perform. If you do a scarf sign, it's very easy for us to cross the upper limb to the opposite side. And if you do a arm recoil, the recoil will be very, very slow. And leg recoil, generally the recoil happens less than 3 seconds, but here the recoil takes almost more than 5 seconds. And the popliteal angle, generally the angle is acute, but in these conditions, the angle is very obtuse. And the heel to ear test in a baby whose tone is normal, it's very difficult for the baby's heel to touch the ear, but the baby with the hypotonia, it's very easy to perform the heel to ear test. These are the features which helps us in identifying hypotonia. And these are the maneuvers which can be performed in a floppy infant. So these are some pull to sit. When you ask pull the baby to sit, see the head is lagging behind. This indicates there is a neck muscle weakness and the baby is floppy. And as the baby is about to sit still, the head is in the midline. But a baby with a normal tone, the head suddenly comes in the midline and the baby flexes the head. This is, and if you make the baby in sitting posture, the back will be curved. In a normal baby, the back is straight. And if you hold the baby in a vertical suspension, the baby slips off and the legs won't be flexed, the legs are straight. And if you do a ventral suspension, see, this is a normal baby, ventral suspension, the back is straight. But here, the baby is curved and this is even more floppy in front, where the baby's head is also low, the hands are directed downwards and the legs are directed downwards. And when you do a prone position, the baby doesn't raise the back. So these are the examination of active tone. So this is a hooked frog posture, but the baby is alert. This is a vertical suspension test. So this is a turn baby on the baby with normal tone. On vertical suspension, the baby flexes the upper limb, the baby flexes the lower limb. But this is a floppy baby. On vertical suspension, the baby slips through the hands and the legs are pointed downwards. And this is making a baby to sit. When sitting, look at the baby's back is curved. This indicates that baby is a floppy baby. We should also measure the amortization angles. These angles are increased. As I discussed, the popliteal angle, the adductor angle, all these angles are generally acute, less than 90 degrees. But in this case, it's increased. The angle becomes obtuse. And if you check the deep tendon reflexes, the deep tendon reflexes are exaggerated in a central hypotonia. In floppy strong babies, it is absent or diminished in the peripheral hypotonia, floppy weak babies. So central hypotonia, as we discussed earlier, there is history suggestive of hypoxic ischemic encephalopathy, birth trauma, or hypoglycemia in the newborn, and the baby will be having a developmental delay, and the baby will be having a dysmorphic feature and other organ malformations. Baby will have a seizure in the newborn period, and the baby is strong, so there is twisting of hands, and deep tendon reflexes will be normal or missed, and there will be features of pseudobulbar palsy, where the tongues are spastic, the jaws that is brisk. And the adaptive response is cross unnecessary because of the increased tone. When you do vertical suspension, in a normal baby, there will be a flexion of the lower limbs. In central hypotonia, there is scissoring of the lower limbs. But in floppy weak baby, there is loosening of the lower limbs and the legs are pointed downwards. In peripheral hypotonia, there is delay in only motor milestones where the language, social, or normal. There is a family history of neuromuscular disorder like myasthenia gravis or maternal myotonic dystrophy. That is reduced or absent spontaneous anti-gravity muscle. The baby lies, when you put the baby in a lying down posture, the baby lies like a frog. You can't perform the anti-gravity activities like lifting the hand above gravity. Deep tendon reflexes are reduced or absent, and the range of movement is very much the loosening of limbs, the range of movement is wide. In frog-leg posture, which we have discussed earlier, and myopathic faces, which we have seen with example, open mouth with tented upper lip, poor lip seal. The baby will always keep the mouth open and sucking. The sucking is very poor. Lack of facial expression, expressionless faces, which I have seen an example with mother and baby's face. Poses in myasthenia gravis, ophthalmic PGR in myasthenia gravis, fasciculation of the tongue, vibratory motions of the tongue, especially in SMA, and wasting and hypertrophy of the muscles in BMG. So these are the localization of the disorders. So in central injury, we will just see the important points. The reflexes are persistent. Okay. In anterior horn the fasciculations are prominent. In peripheral nerve, there is a distal weakness. In neuromuscular junction, there is predominant of ptosis involvement, and in myopathies, there is absent reflex and proximal weakness. So the investigations has to be done in case of central hypotonia. So what are the causes? Hypoxic ischemic encephalopathy, you have to do an MRI brain. Down syndrome, karyotyping has to be done for Down syndrome. Hypothyroidism is suppressed, TFT has to be done. And electrolyte abnormalities to do electrolytes and mucopolysaccharidosis and organic acidemias. Check urine for mucopolysaccharidosis, organic acidemias, and Wilson's disease and Memphis disease. Check serum protein and ceruloplasmin and plasma very long chain fatty acid for Zellweger syndrome. In case of peripheral hypotonia, there is elevation of the muscle enzymes like serum, creatine, phosphokinase, and LDH. Serum lactate in case of mitochondrial myopathies. Nerve conduction studies and repetitive nerve stimulation, EMG, all these in case of neuropathy, especially this repetitive nerve stimulation test in myasthenia gravis, muscle biopsy in myopathies, and metabolic myopathies like Pompe's disease, and genetic history. So these are the various differentiation. In central disorder, the deep tendon reflexes are increased. The EMG and muscle biopsy are absolutely normal. In anterior console, the deep tendon reflexes are absent, floppy weak, but there is fasciculation or fibrillation in the EMG. The muscle biopsy shows denervation pattern. In peripheral nerve, deep tendon reflexes are decreased. EMG shows a fibrillation pattern. Muscle biopsy shows a denervation pattern. So anterior console and peripheral nerve are almost the same. The classical feature is fasciculation in the anterior console. Neuromuscular junction, the deep tendon reflex can be normal. EMG is the RNST, repetitive nerve stimulation test shows a decremental response. Muscle biopsy is normal. In myopathy, the deep tendon reflex is decreased. The muscle EMG action potential is of short duration, and the muscle biopsy is the diagnostic test. These are the diagnostic kind of various things. So out of this, the history, physical examination, which I have discussed a long family history, all contributes in clinical neurological examination 50% of diagnosis. So this is our approach to diagnose for history and physical examination. We'll just identify 50%, and based on the floppy strong or floppy weak, further diagnosis can be proceeded. So treatment principles, physiotherapy. Main aim is to prevent the contractures, occupational therapy, and when there is an associated cardiac dysfunction or aspiration pneumonia, treat them and new respiratory support them. Feeding with an astrogastric tube, orthopedic interventions to prevent joint contracture, and early stimulation and prevention of respiratory infections, and genetic team is required for the diagnosis. These are the specific therapies available, like Spinraza, like nusinersen approved for SMA, and onasimnosine, which is a gene therapy approved for spinal muscular atrophy. This is a biozyme approved for Pompe disease. So for hypothyroidism, thyroxine supplementation has to be done. A state cholinesterase inhibitor for myasthenia gravis and rickets and erectile disturbances has to be managed. So the take-home points are hypotonia has to be considered as a symptom, and based on the approach, you have to classify into a floppy strong and floppy weak, and then arrive at a particular diagnosis. Don't jump onto a diagnosis. Thorough history and clear physical examination is very, very important because it helps us in identifying 50% of cases and focus. The specific etiology has to be treated. Don't start a cocktail regimen. If hypothyroidism, treat hypothyroidism. If Down syndrome, treat Down syndrome. So these are my references. Thank you.